You're listening to Admitting Diagnosis, the Journal Watch podcast for the week ending July 4th, Independence Day hereabouts. I'm Joe Elia. We offer a very brief roundup of the short week's news, along with an interview. This week, we talk with Luigi Ferrucci about his research on subtle neurologic abnormalities in older people and their prognostic value. If you'd like to leave us a comment, and we hope you will, call 617-440-4374. That's 617-440-4374. Story links are available at podcasts.jwatch.org. Okay, here are the week's top medical stories in brief. There are just two. The first concerns survival trends in HIV, and the second deals with management of non-STEMI acute coronary syndromes. Here they are. JAMA reports that HIV-positive patients from industrialized countries are surviving their infections better than ever. In fact, the mortality rate in the first 5 years after infection is about the same as in the uninfected population. Good news for the short term. However, excess mortality due to HIV is still evident in those infected for 10 years or more. Writing in Journal Watch HIV/AIDS, Paul Sachs says that as treatments continue to improve, so will the period of equal survival. Our other top story of the week also comes from JAMA, where researchers report that management of non-ST elevation coronary syndromes should differ between men and women. Their meta-analysis of 8 randomized trials found that invasive management, that is, angiography with revascularization as needed, was less dangerous in men and high-risk women than it was in low-risk women. Low-risk women showed a higher rate of the composite endpoint of death, non-fatal MI, or rehospitalization when treated aggressively. The authors say their data provide support for new guidelines from the major heart health organizations recommending conservative management in low-risk women. Here is this week's Journal Watch interview. Last week, researchers reported that subtle neurologic abnormalities detectable on routine clinical exam can provide important prognostic information on death and disability in older people. Their research, published in the Archives of Internal Medicine, focused on some 500 neurologically and cognitively normal adults, 65 and older, living in a rural town near Florence, Italy. The subjects underwent a baseline exam and were then followed up for about 8 years. The research found that subjects with greater numbers of subtle abnormalities, and these were things like resting tremor or postural instability, had a greater likelihood of disability or death in the follow-up period. Dr. Luigi Ferrucci, one of the researchers on the project, has agreed to talk with us about these findings. Dr. Ferrucci works at the NIH's Institute on Aging in Bethesda. Welcome, Dr. Ferrucci, and thank you for agreeing to speak with us today.
Oh, it's a pleasure to be here.
Can you describe briefly some of those subtle abnormalities and how detectable they are on routine exam?
Yeah, I can easily do that. When you go to a doctor and they do a routine neurological examination, some of the things that are frequently tested are your ability to maintain balance with your eyes open and with your eye closed, some of the asymmetries in your muscle strength, and whether your neurological reflex are normal or hyperkinetic or hyperkinetic. And one of the things that has been done in the past is most of the time ignore these soft neurological signs, pretending that, especially in older people, the emergence of this clinical sign, it's a normal finding, so it should not be given too much importance. And what this research is showing is that they are very, very important, and because they are associated with disability, but especially because they predict disability over time, are also associated with mortality. So when these findings are detected, we need really to look into them and understand what is their origin, because hopefully most of the time that are related to conditions that can be managed and treated.
You said that you had looked at the cohort that you studied, about 500 people, were neurologically normal at the beginning of at baseline.
Yeah. So the issue is they did not have any overt neurological disease or neurological diagnosis. So they never had a stroke before or any clinical manifestation that could be interpreted as a stroke. They did not have any Parkinson's disease or peripheral neuropathy. But as many doctors that are dealing with older patients know quite well, you can have, subtle ischemic strokes, even silent ischemic strokes that are damaging little part of the brain and cause neurological abnormality that are minimum localized to a specific trait or to a specific muscle, and so they do not really configure clinically an overt neurological condition, but they are the equivalent of a neurological condition that is subclinical.
And over time, you found that you did 2 follow-ups, right? You did one at 4 years and then one at 8 years. And the one at 4 years was for cognitive impairment?
Yes.
And you found that the people who had, you have a list of about 15 of these signs, is that right?
Yeah.
And the people who had 3 or more of those signs on clinical exam were more likely to be showing signs of cognitive impairments at the 4-year mark, right?
Yes.
And by the end of 8 years, they were found to have a higher increase, or they'd be at a higher risk for death.
Yeah.
In addition to that, and so these were just these predictions or these associations were seen just on the basis of very simple tests that I think the paper says most people do during a routine physical exam.
Yeah, if you do an accurate neurological examination during your physical exam, you will find these signs. So I think that one of the issues that need to be specified and underlined here is that the recent literature has shown how cognition and mobility and physical disability are highly connected. So people that have cognitive problems are also those that are more likely to develop physical function problem, and on the other side, people that have physical function problem are also those that are more likely to develop cognition problem. And so, in a way, there is a common basis, a common pathological background that in older person connect the cognition and physical function. So this paper actually suggests and strongly suggests in a very well-characterized population that the common trait between this condition is neurological integrity. And something that I have to tell you is that the part of the brain that caused physical function decline with the aging process has been overlooked in the past. So everybody was concentrating on the effect of osteoporosis, on muscles, on peripheral nerve function, and here clearly we show that the central nervous system and the brain are really, really important for these changes that occur in older people. So we need to focus our preventive strategies on the brain much more.
And you said in the paper that earlier research had found that these abnormalities plus imaging were predicting rates of decline. And you set out with this research to show that you could predict that decline just on the basis of the exam alone.
Well, I mean, there is been previous research showing that if you have small localized silent stroke in the brain, but also some lesion in the subcortex, in the white matter of the cortex. Those people with this pathology tends to decline physically. And the question is that while this is mechanistically very important to be demonstrated, we cannot really do an MRI or a CT for screening people. And so this is useful to know, but it cannot be directly translated into clinical practice. On the contrary, if you could capture those subtle neurological abnormality by doing a physical examination, then, especially in older people, you could screen for those signs in a routine clinical practice and maybe identify more people that have a high risk of developing outcomes and intervene on them at an early stage when it's still possible to interrupt the causal link that will eventually lead to those outcomes.
And there are a total of, 19 possible abnormalities because two of them are can be unilateral.
Yes.
And that list is available in your paper. And the cutoff point is 3. And if you have more than 3 of these things, you're in trouble, so to speak.
Yeah.
Or
Well, I mean, the one thing that here needs to be underlined is that 3 is not a magic number. Mm-hmm. What's important is that having one single abnormality can really be due by chance, or can be due to the fact that you have a specific problem that may not be evolving. When you have more than 3 multiple problems, the probability that you have the condition that is spreading in different parts of the brain and so is more likely to be evolving is much higher. This is one of the theory that is typically entering in the science of the aging process, where multiple physiological damage is predictive of accelerated decline of physical function, cognitive function, and mortality. And even the neurological signs are not exceptions. So we put the threshold at 3, but there is a linear increase in the risk above 3.
Above 3. Would you recommend using that clinicians in practice start using that scoring system, or do you need to do more work before it's ready for routine use?
Well, I mean, there is certainly, I don't know whether you read in the introduction, this is a study that was done. We did a previous study in a Tuscany population, another Tuscany population, in the Chianti study, and we show cross-sectionally that the number of neurological signs was associated with physical function and with the risk of falls. And this study is done a step forward because not only look at the cross-sectional association, but look at the predictive model, where measuring the neurological sign actually predict what's going to happen in the next 4 years. Yes. The problem with those studies is that they're done in Italy, so they are done in a very, very specific population that lives in an area where, nutrition and physical activity are quite different from those of other countries, such as the United States. So I think that before this results could be applied to the general population and in general clinical practice, they will need to be replicated in other U.S. and maybe other countries' population, and maybe in larger population, because 500 people seems to be a large population, but in order to really decide whether you want to translate this method into clinical practice, the sample size to be studied should be much larger than that. So why these results are very, very promising and very, very solid, and so required to be replicated and to lead to further research, and will probably eventually be applicable in clinical practice, I will not say that the score should be currently employed into clinical practice.
I see. And do you mind my asking, are you engaged in any research now to study this scoring system in...
well, you know that from my accent that I'm Italian, but I've been working at NIH for 5 years. And in Baltimore, I am the director of the Baltimore Longitudinal Study on Aging, which is the oldest study on aging that had never been launched. I mean, the study is 50 years old, so we have collected information on neurological signs in these individuals, some of them for about 40 years, and they're still participating in the study. So we are actually trying to validate those findings in the Baltimore Longitudinal Study of Aging by using retrospective information and an analysis of the medical charts.
That'll be interesting to see. I hope you get back to Italy from time to time.
I go to Italy all the time. Working in the United States is beautiful, but tomatoes are much more beautiful and tasteful in Italy.
And there's less salmonella on them so far. All right, Dr. Ferrucci, thank you so much for your time with us today. And we look forward to hearing more about this research.
Good.
Finally this week, Voyager II is leaving the heliosphere. After a 30-year flight, the intrepid little space probe now heads out beyond the influence of the sun, high gas prices, and drug detailers. I'm a little jealous. If you'd like to talk about Voyager or something else, feel free. Call 617-440-4374. Just leave your name and number so I can get back to you and get your permission to put your comments on the podcast. Story links are available at podcasts.jwatch.org. For the Journal Watch podcast, I'm Joe Elia.